Welcome to the American Medical Association Physician Education Podcast on the opioid overdose epidemic. Through expert discussions and insights, this podcast will feature information that can help physicians of all specialties address the epidemic of opioid overdoses. Free CME is available. I'm Dr. Bobby Mukamala, board-certified otolaryngologist and a member of the American Medical Association Board of Trustees. Viewed through an evidence-based lens, opioid use disorder is a treatable chronic medical condition. But one-size-fits-all policies and detoxification as a primary treatment for opioid use disorder are, at best, ineffective and at worst, cause harm. In this episode, we discuss applying a prevention framework to guide action and policy through prevention, treatment, and harm reduction. Using data-driven processes that consider predisposing risk factors and social determinants of health, a prevention approach can offer a physician a powerful tool to combat opioid use disorder. Joining me is Dr. Catherine Livingston, Medical Director at HealthShare of Oregon. Dr. Livingston is a family physician with special expertise in evidence-based medicine and is an expert in epidemiology, the study of health issues among populations of people. Welcome, Dr. Livingston.
Thank you, Bobby. I'm delighted to be here.
So can you share with our listeners a bit about your work and research? What drew you to this subject?
So my clinical background is in family medicine as well as preventive medicine. And so I have this really interesting opportunity to both care for individuals as well as populations. I work in a urban federally qualified health center, and I take care of a lot of patients with addiction issues. But I also spend most of my time working on the policy level for Medicaid. So I serve as the medical director of a coordinated care organization in Oregon, and we have about 450,000 Medicaid members. So in that job, I get to think about what kind of population strategies that we can do to improve the lives of people with substance use disorder and ideally prevent substance use disorders from happening in the first place. I brought this topic to the American College of Preventive Medicine to really think about, from a preventive medicine view, what is it that ACPM, the American College of Preventive Medicine, can really offer in terms of thinking about prevention strategies for the opioid use disorder epidemic.
Thanks for that overview. Can you start us off with an overview of the prevention framework? So what's the background of this approach and how has it been used with opioid use disorder patients?
A prevention framework is a standard preventive medicine or public health approach to addressing chronic diseases. The idea of a prevention framework is really to look across the continuum of a chronic disease and identify along that continuum what are the predisposing factors that can be modified. There are robust models of using this type of prevention framework with things like diabetes and hypertension and congestive heart failure. And so I think what's incredibly valuable about using this prevention framework is to really think across the spectrum of a chronic disease before it's developed, in its early stages, in its mid stages, and then really at end stage chronic disease. What are all the strategies that you can potentially do to decrease those risk factors and ameliorate the consequences of the disease? So then you asked, how has it been used for opioid use disorder? It hadn't. And so that's part of the reason that we really wanted to look at this and figure out, if we do look at how we've been approaching the opioid use disorder epidemic from a prevention framework, are we really intervening along all the stages of prevention, or are there big gaps in terms of where we're actually focusing our strategies?
And what first drew you to this approach? Can you share an example of when you first realized the potential of this approach for opioid use disorder?
I think with the opioid epidemic, there have been a multitude of strategies instituted across the nation. Many of these were focused primarily on opioid prescribing. We had legislatures cracking down, some with extreme examples of physicians being scared to prescribe necessary medications in fear of board reprimands. There's been a lot of great work around prescription drug monitoring databases in terms of really enabling physicians to make informed decisions about prescribing. I think some of these strategies were more carrot-focused and some were more stick-focused. And at the time, we were all responding to the fact that people were dying, and it was a really scary epidemic, rapidly emerging. So we were doing all of this in an evidence vacuum, but we just wanted to stop the hemorrhaging that was the opioid overdose epidemic. So now I think we have time to really sit back and think comprehensively with a much greater evidence-based about what are all the things we need to do from a policy and clinical level to really improve the systems as well as individual clinical care. And so when I looked at all the documents for like how we should be addressing the opioid use disorder epidemic, there were all these documents that were hundreds of pages long, and some of them still seemed to be missing big components. Like maybe they were all focused on prescribing or all about the PDMP. And so the prevention framework seemed like a way to step back and really think about those strategies across the whole continuum, and then figure out where the gaps in our focus were. In primary care, well, actually, especially in hospital medicine, I think that's really where I feel the urgency to work in the prevention space the most. I would think about a patient who came in, who was homeless, used IV drugs, and had a chronic festering wound on his foot and needed an amputation. So for the case of this person, obviously providing really robust medical care, supportive care around the amputation, providing inpatient treatment of his opioid use disorder, and then ideally would have transitioned him to really fantastic outpatient care, but we discharged him to the streets because that's where he lived and he didn't have housing and he probably wasn't going to get reconnected back to treatment. And then knowing that with that patient and many others like him, that he was going to end up back in the hospital with another infection or endocarditis or possibly even dead. These are the heartbreaking stories of medicine where we really try and think about what is it that we can do more broadly at a systems level to really think about how is it that we can serve people like this better. That's where my passion from this comes from, is really trying to figure out what are those system solutions that can really help address the moral distress that I think many of us feel when taking care of patients like this, where things are way more complex than just being able to address the individual who is in front of us.
Yeah, what you just described is always such a frustrating thing, taking care of the patient in the acute setting and then sending them home, knowing that what caused that acute event is still out there and is likely to do it again, particularly in patients with opioid use disorder. So can you walk us through the four components of the prevention framework when it's applied to opioid use disorder?
The four components are, first at a high level, primordial prevention, primary prevention, secondary prevention, and tertiary prevention. And I think most of the time, actually, even in public health and preventive medicine, when we talk about the prevention framework, they kind of only talk about those three, the primary, secondary, and tertiary. And really where I get very excited is when we think about primordial prevention. So that's really where you're starting to address what are the underlying structures that contribute to developing disease in the first place. And so that's really where we think about things like social determinants of health. Poverty is a key one, certainly in the space I work in with Medicaid. Racism, food insecurity, housing insecurity. These are the things that create lifelong risk for a number of different chronic diseases, including opioid use disorder. Another key primordial prevention area to think about with opioid use disorder would be adverse childhood experiences, or ACEs. So these are things like neglect or abuse or death of a parent. And the data shows that kids who experience ACEs and multiples of ACEs have much higher risk of opioid use disorder in the future, somewhere between 6 to 10-fold increased risk. And so if we're starting to think about what are primordial prevention strategies where we can really decrease future risk of opioid use disorder, something like addressing adverse childhood events or social determinants of health, these are really key population level strategies that we could do to really transform future risk of developing disease.
For so many conditions that we help patients with, we often feel frustration about our inability to address the social determinants of health. So can you share an example of how you as a physician have been able to address social determinants of health, or ACEs? I imagine that this would be sort of a team-based approach to these issues.
Yeah, so I'll give an example of both social determinants of health and then ACEs. So for social determinants of health, I think many of us in our clinical systems are starting to do social needs screening. This has been starting in hospitals, it's in a lot of primary care settings, and it's really interesting and exciting and really pushing healthcare in new ways. I do think it's important to caveat that we are not, when we're doing that, we are probably not addressing social determinants of health. We are really looking at an individual level health-related social needs. So my patient in front of me needs food support. So me as a primary care doctor, I can connect them to a phone number. I can connect them with a food box, refer them to community resources. That's fantastic at the individual level. So this is a case where, by addressing an individual's food insecurity or housing insecurity or need to connect to a domestic violence shelter, we can make a really powerful difference in that individual's life. And that can really help them, particularly on their trajectory if they're struggling with opioid use disorder, getting housing stabilized or food stabilized, transportation stabilized. Those things can really help people engage with medical treatment and get back on a path of engagement with medical care. I do want to be clear that that's not necessarily addressing social determinants of health, because that would really be addressing the system structures that cause those things in the first place, that cause the housing insecurity and the food insecurity. So I'd love to give an example of something that prevents adverse childhood events. The Medicaid coordinated care organization that I work for started something called Project Nurture, which is an integrated maternity and addiction model that provides care for pregnant people with substance use disorder. So I would say that in a lot of parts of the country, if a pregnant person has substance use disorder, then she, might see a maternity provider and separately see an addiction provider. Those people may or may not have communication and coordination with each other. She may or may not necessarily be offered evidence-based care for her addiction during pregnancy. Hopefully would not be discouraged from taking buprenorphine or methadone, which are evidence-based also in pregnancy. But this particular project, what it did is have under one roof maternity care and addiction care and peer support and group support all provided together, and has been shown in a 2020 study to decrease foster care placement of the kids, as well as decrease child neglect. And so if we think about the impact of projects such as this that really transform the kind of care that we're providing to people and decrease adverse childhood events, we are potentially decreasing future generations ending up with increased risk of opioid use disorder. All right, so that was primordial prevention. And so moving into primary prevention. So this is reducing the risk of developing opioid use disorder in the first place. And I think this is where most of the work really has happened. When the opioid use disorder epidemic started, there was so much work in terms of prescription opioid prescribing. We had the CDC guidelines, prescription drug monitoring programs, legislative action to try and decrease prescribing. So really, this is decreasing access, largely to prescription opioids, where there's been a ton of work in that primary prevention space. And the idea is that if people have less exposure to prescription opioids or illicit opioids, there will be less addiction that happens.
You talk about child and adolescent patients. I imagine that ethical considerations may come into play. So can you share your thoughts on applying the prevention framework with patients such as minors or other populations that may be controversial to some?
So I think from an ethical perspective, preventing harm would be ideal. But it's a lot easier for people to see a problem that already exists and identify it needing to be solved, rather than proactively invest and support strategies to prevent the harm from happening in the first place. So it seems like even though ethically we may be more challenged to say preventing it would be more of an ethical imperative, it does seem like primary and secondary prevention are often more palatable. For kids, we actually have really good evidence that adolescent middle school programs decrease the incidence of opioid use disorder by about 40%. So from an ethical perspective, I would say that seems like a no-brainer. We should absolutely be investing in these middle school programs. But there are a lot of thoughts about what should or shouldn't be taught in schools and what funding should go to or not go to. And so when we run into that lack of clarity or around those differing opinions, I think that really creates difficulty in this space.
Can you talk to us next then about secondary prevention?
Secondary prevention is early identification and linkage to evidence-based treatment. So really most important in the secondary prevention space here is medications for opioid use disorder, methadone, buprenorphine, as well as naltrexone. So there are a lot of barriers to methadone and buprenorphine. There's a lot of geographic limitations. For decades, people could really only meaningfully access methadone and opioid treatment programs, which were largely localized in urban areas, difficult to get to, required daily dosing. And so really, there's been so much fantastic opportunity in the last decade, really, where buprenorphine has really expanded. We're seeing it in primary care. There's a lot of really neat work happening in emergency departments, expanding low barrier access to buprenorphine. And so I think all of this is sort of tying into the fact that opioid use disorder is now really being recognized as a chronic disease. And it's not just something that needs to be outcast in terms of its benefits treatment in opioid treatment programs, but also fully built into primary care so we can treat addiction just like any other chronic disease. I think one of the things to consider in secondary prevention is, and you mentioned this when we first started, is that a lot of people just get recommended detox. And detoxification alone is not a treatment for opioid use disorder. It is one step as you initiate medications for opioid use disorder, but it in itself is not a standalone treatment. And I think a lot of people, unfortunately, end up just getting recommended to that and not actually connected to the effective treatments, which are the medications for opioid use disorder. There is one population I would like to highlight is those in carceral settings. A lot of people in carceral settings don't have access to medications for opioid use disorder. And when they're released into community, their rates of overdose are extraordinarily high with a very high risk of death. There's extraordinary opportunity to really think about these high-risk populations like those in carceral settings and potentially, if not treat them while they're in the carceral setting, at least as they're exiting back into community, really make sure that they're deeply connected with treatment for opioid use disorder to decrease their risk of overdose and decrease their risk of recidivism as well.
Yeah, you mentioned the incarcerated population, but I imagine that the pregnant population is also one that sort of is subject to a lot of social or cultural bias in treatment. So how do you address that cultural bias about treating patients with opioid use disorder, those that are pregnant or those that might be incarcerated?
The cultural bias is really significant. There's so much stigma, especially with pregnant people. I recall a high-level state policymaker at a meeting I was at say that people with opioid use disorder deserve to suffer with withdrawal while they were in jail, as sort of just a punitive, stigmatized belief that people deserved to suffer. And so how do we solve that? I don't know. That's really complicated. I think normalizing this as a chronic disease is really, really important. Slow change over time is going to be necessary as people realize that addiction absolutely is a full part of our community, and many people are able to live fully functional, happy lives as long as they're getting effective treatment and connection to care. But I think that this is a lot of work that needs to be done in front of us. I think pregnant people especially face a lot of this stigma. And unfortunately, many of them are avoiding access to maternity care because they're facing so much stigma that they don't want to engage because there's so much fear and shame that's associated with it. And then the harms are obviously not just to the pregnant person, but also to the fetus or infant.
Absolutely. I think you're spot on about the challenges there. So, and lastly, we have tertiary prevention. Can you tell us about that aspect?
Tertiary prevention is where things get pretty interesting and controversial. Primary prevention, people feel good about that. That makes sense. Decreasing opioid prescribing. Secondary prevention, that's really gaining more traction, that medications for opioid use disorder are standard of care. But tertiary prevention, that's where there's a lot of heated debate in this space. The idea, though, behind tertiary prevention is really to slow progression of a condition or reduce negative consequences. With opioid use disorder, this would be reducing complications like overdose deaths or infection-associated diseases like Hep C or HIV, and reducing complications. I think it's also important to note that not all people who use drugs are interested in discontinuing, but still there are opportunities to decrease morbidity and mortality, even if they aren't interested in discontinuing their use. There are three main evidence-based strategies. There's syringe services programs, there's naloxone, and there's housing first models, which get people into housing before discontinuing drug use. Naloxone has become really well accepted, so I would say is much less controversial than some of these other ones, and has really been effective at saving lives, decreasing overdoses in a variety of different settings across the nation. Some of the ones that are under investigation are supervised consumption sites or overdose prevention sites. These are really quite controversial. I think New York City was the first one in 2021 to open two of these. But these definitely raise a number of community concerns, and our country has been less interested in engaging than some others like Australia and Canada. And then decriminalization is another strategy in the tertiary prevention space that some are trying, including my state of Oregon. I think we have a lot to learn from the successes and failures of projects such as that.
Yeah, I imagine. I mean, you've alluded to some of the controversy around some of these solutions in tertiary prevention. What's the process of creating a harm reduction policy look like? Can you share some examples of successes you've seen and the impact it's made on the community?
The most successful has certainly been with naloxone. We have two real opportunities. One is in the healthcare space where we are prescribing a lot more naloxone, so co-prescribing whenever we're doing high-dose opioids for people who are on benzodiazepines and opioids, building that in as part of standard of care that both physicians can prescribe, pharmacists are able to co-prescribe that. But there's also the community availability wing where we have emergency medical services carrying naloxone, community paramedics providing this. And both of these simultaneous strategies, the ones within the healthcare system and the ones within the community, are really effective at decreasing things like emergency department visits and overdose deaths. So I feel like naloxone is probably the greatest success story. Syringe services programs have been around for a long time and are effective at decreasing HIV rates and hepatitis C rates. Also, when you have a syringe services program that people are engaging with, there's a 5 times higher risk in one classic study of potentially engaging with care and getting medications for opioid use disorder. So these are effective at getting people potentially engaged in care as well as decreasing infectious disease risk.
Thank you. Your research and practice are certainly encouraging in addressing opioid use disorder. And as we bring our discussion to a close, what are the opportunities you see for the future of applying the prevention framework?
We need to focus more upstream. I think we need to focus on primordial and primary prevention more. The primordial prevention, I feel like, gets a lot of word attention, but not necessarily meaningful engagement. And so thinking about what is it that we need to do for children and adolescents to really decrease a future generation's risk of having opioid use disorder. So much of our conversation has really been on adults who are currently using opioids. And I'd really love us to really focus that attention more upstream on how we prevent people from using it, including children who one day will become adults who hopefully will have lower risk of using opioids and developing opioid use disorder in the future. I think some of the other key opportunities, I get to work in the payer space, but really making sure that our systems that are paying for the different interventions, so whether that's multimodal pain control or effective medications for opioid use disorder, making sure that there are decreased barriers to effective evidence-based treatments for opioid use disorder, as well as multimodal pain control. One of the other areas that I think that we have a lot of growth opportunity, but is really the best in terms of opportunity for transformation, is cross-sector partnership with education, with the housing sectors, public health, and healthcare. So one of the really cool things that I have gotten to work on is a housing pilot. We're essentially using Medicaid funds to pay for housing supports for 12 months for people who have substance use disorders. And so really, we don't have the data on it yet, but really trying to understand if we are able to give people supportive housing for up to 12 months, how does that change their trajectory? How does that change their inpatient admissions? Does that allow enough stabilization for them to potentially engage in care and move into a more stabilized health environment? And the final one that I would recommend is really focusing on carceral transitions. It's super scary that people get released from carceral settings into community, often with very little supports, no connection to housing or healthcare, behavioral health, or opioid use disorder treatment. And so really figuring out how can we build a really nice model of care around people who are leaving carceral settings to really help them to succeed.
Thank you. As we come to a close now, what would you say to our listeners to encourage them to meet these challenges that we've talked about and advocate for the best outcomes for their patients?
The opioid use disorder epidemic has really challenged our profession in thinking about what are our roles as clinicians, as healthcare leaders, and as policymakers in improving outcomes. So I think it's critical that we think across this prevention spectrum. Are we doing everything that we as physicians can and should in each of these areas? Are we doing anything in the primordial prevention space? And what is our role as clinicians? Like, what can we be doing to prevent ACEs, adverse childhood events? In the primary prevention space, I think we're doing a lot of really fantastic stuff in terms of curbing opioid prescribing that's inappropriate, but we're not doing enough in terms of enhancing protective factors and reducing those risk factors. So really thinking about how can we build not just the stick part of things, but also the carrot. In secondary prevention, I think we've done a lot of fantastic work in the last 2 decades in this, but, can we get to a point where every primary care office is offering buprenorphine and we're effectively treating people with medications for opioid use disorder in whatever setting they present? I think there's a lot more work we can do there. And finally, with tertiary prevention, certainly expanded access to naloxone everywhere, and then really understanding these other harm reduction efforts. What are the ways that we can build those into our communities? I think there's a lot of work to do and a lot of evidence yet to be developed in that space. So I think we aren't doing enough yet. And we aren't doing it across enough sectors. And we have enough evidence at this point to really understand what are those effective strategies and what are those strategies that might have unintended consequences, to really try and refocus our attention and really think about how can we build more in the primordial prevention space? How can we think about children and adolescents as a really critical population? How can we think about pregnant people and carceral, these transition populations who are also incredibly important? So I think there's a lot more work to be done. And for me, this prevention framework helps to think, where are those gaps and where should our future efforts focus on?
Absolutely, yes. I think the way that you frame these opportunities is great, thinking about things other than our traditional healthcare spaces to really impact the consequences of opioid use disorder in our country. Kat, thank you so much for your pioneering work and for joining us today.
Thank you so much.
And thank you to everyone for listening, and we'll see you next time. Thank you for listening to the American Medical Association Physician Education Podcast on the opioid overdose epidemic. Make sure you tune in to other episodes of this series to learn more about opioid use disorder, and harm reduction. Visit the Resources tab to learn more. Complete the quiz to earn CME.